My name is Paul McGann, and I'm the Chief Medical Officer for Quality Improvement for CMS. Hospital Improvement Innovation Networks, or HINs, are a concept that emerged out of the CMS Innovation Center starting in around 2011 and 2012. There's about 32 million people admitted to acute care hospitals in 5,000 hospitals in the United States every year. And those patients, unfortunately, still experience a fairly high level of harm, not from the disease that brought them to the hospital, but because of the high-tech interventions and all of the complicated medications that are administered to them while they stay in the hospital. And we call that patient harm caused in the hospital. And the HINs have been developed as a system to reduce the amount of harm that patients experience in hospital. And the concept is that a network of quality improvement and collaborative quality improvement can be established on the basis of very specific and very ambitious aims. I call it kind of the moonshot approach to quality improvement. And what happens in this form of quality improvement is that focused areas are identified of need in public safety and the improvement of quality, in this case in hospitals. And best-in-class performance is examined from around the United States to find examples of really tremendous improvement that goes well beyond the average. And in the initial formulation of this type of quality improvement, we identified two aims of this nature. One was to reduce preventable harms in all 5,000 acute care hospitals by 40%. And the second aim was to reduce 30-day readmissions of all cause, all payer, by 20% over the course of a 3 or 4 year program of work. And that's how this HIN concept started. What we've done recently, and we talked about at our recent quality conference, is back in September we awarded the most mature round of these HIN contracts, September 2016. And these contracts have now been coupled and linked, embedded really into the QIN-QIO program writ large. And in fact, of the 16 HIN contracts that are in the field today, 2 of them are QIN-QIOs. So the merger really is complete, and we'll have more competitions in the future, and more QIN-QIOs might join with this movement. And the movement is characterized by these 2 characteristics. The first is to target very specific results that are generated rapidly. And the second is to move quickly and adapt quickly to changing circumstances. So very bold targets that are focused in a laser-like way, and the ability to move and change and adapt to changing circumstances, which is important now with health care delivery reform, in the environment, so that things happen quickly and seamlessly, and that we keep up with the rapid changes around us. In the particular case of the HIN contracts awarded in September, we have a new set of goals. And the new set of goals is to reduce all causes of harm by 20% and to reduce 30-day readmissions by 12% by 2019. And the entire system of contracts, networks, and collaborative improvement is oriented around those 2 goals. And we also aim big. We aim to reach the entire country. And so these HIN contractors are going out. We're aiming for all 5,000 short-stay acute care hospitals in the United States, and we already have a system in place that's going to hit more than 4,000 of them. And over the next 3 years, we hope to accumulate more and more so that we approach the 5,000 total participation of the United States. How does this change? How does this addition and enhancement of the QIN-QIO program help, first of all, hospitals, and secondly, beneficiaries? Well, in the hospital's case, because the basic QIN-QIO contract was modified, we have a lot more clarity now, starting in 2016 and continuing on into the future, of what it is and what technical assistance hospitals have access to. The HIN concept of collaborative quality improvement in short-stay acute care hospitals is now laser-like focused on more than 4,000 hospitals in the United States, and it's clear to the hospitals that are seeking technical assistance for quality improvement from CMS, where that's going to come from, because it's in the HIN contracts now, 2 of which are QIN-QIOs. So from an institution's point of view, they now have a focused, clear source of technical assistance, and they also know that they're going to focus their efforts within the hospital on improving patient safety and on improving care coordination from within the hospital. Now, an important interface with the rest of the QIO program is with the community-based work that the QIN-QIOs already have in the 11th Statement of Work. And as you know, there's been tremendous work already in 300 communities around the country from the QIN-QIOs on community-based work also to improve care coordination and reduce admissions and readmissions, and as well to improve adverse drug events, which also needs to happen in the hospital. So very important concept of collaboration, alignment, and coordination comes to play here, which also benefits the institutions because it makes it clear to them exactly how the technical assistance is going to happen. In terms of benefits to the beneficiary, I think what happens now is that all of the effort from all of our quality improvement programs at CMS are all aligned toward a very single, easily understandable goal, particularly within the hospital setting. When we meet with patients and patient representatives, when we involve them in the creation of this work and even in our learning sessions, what we are able to tell patients and patient advocates who have suffered harm or their loved ones have suffered harms, or some of them have even died from medical errors in hospitals, is that we have a measurement system now called the AHRQ National Scorecard, which comes with the HINs, where we can actually count the number of harms per 1,000 discharges in hospitals nationwide. And when we tell that to beneficiaries, it's clear to them, first of all, that we know what we're aiming for. We're trying to reduce all causes of harm in all hospitals in the United States. And secondly, we have a very, very sophisticated system of measurement that lets us track our progress. We've already reduced the all-cause harm in the United States from a baseline year of 2010 of 145 harms per 1,000 discharges to 121 harms per 1,000 discharges in 2014. And our new goal is to drive that harm rate down even further by the end of the HIN contracts to 97 harms per 1,000 discharges, which is going to be the lowest harm rate in American hospitals that's ever been recorded. So we have tremendous new systems that are aligned with each other, that reinforce each other, and which are going to generate patient safety results that have never been seen before, which beneficiaries always appreciate. Now, if you think about it for a minute, that's good results, and we're happy that it's happening, but 100 harms for every 1,000 discharges is nothing to be proud of. So the task for us in the future is to figure out how to drive that harm rate even lower and get it down, hopefully, as close to zero as we can get it. The AHRQ National Scorecard helps us keep track of that. But it's really your efforts, all the QIN-QIOs, all of the providers, all of the patients that join with us in this effort, and now the HINs that have been brought into the QIN-QIO program, they're actually going to make the results happen and get that harm rate as close to zero as we possibly can get it.